Thank you, Chairman, Co-Chairman, and greetings to the audience. My name is Chantas Mahaisavariya from Sirat Kanchana, Faculty of Medicine, Sirat Hospital. Today I would like to share my experience of the cases. So this means it's the sharing the case, not the lecture. So I would like to close the light for facilitate you to see the clear view of the distal and radius X-ray, from the X-ray to the operations. So first of all, this one, the distal radius fracture, is one of the most fracture that you encounter in the emergency room, and it has bimodal distribution from the motor vehicle collisions in the younger patients to just common fallings in the elderly patients. And this is one of the common osteoporotic fractures. And right now, there is a trend towards the surgical treatments that give the favorable outcome more than casting. So current classification that we use are Fernandez, which is classified by the mechanism of injuries, or fragment, Malone, or Mayo that classified by the articular fracture patterns, or the universal classification which try to simplify everything. But in this study, the current study that shows the reliability of each classification, we saw that there's just give only average kappa values. So right now there is no single robust classifications. So to evaluate the fracture fragments, first I would like to see the radial columns, which is usually a large and intact, which is the radial styloid. Another column is the lunate facet, which is a keystone, because this one is acting like a load transmission from the middle finger to the metacarpal bones, to the capitate, lunate, and then to the wrist. So this one is very important. And the dorsal cortex integrities, which if there is a comminution, according to Lafontaine criteria that proposed long ago, it will lose the reduction and turn into the dorsal tube. Or the radial translation of the distal fragment, which is caused by the brachioradialis deforming force. So this is my operative strategy. First, I emphasize you to do the adequate initial reductions in every cases. And after that, please evaluate the keystone fragment and include the radial column, the radial styloid, the lunate facet. Another thing is evaluate the degree of the comminutions, which makes the fracture more complicated. Don't forget to look for the osteoporotic bone, because when there is a radial collapse and you try to reduce, they will create the void. And if you doesn't fill the space, it will collapse in the further follow-ups. And please look for the associated distal ulnar fracture when you have to fix it. So in the audience, please raise your hand if you think this case is complicated. Please raise your hand. Please raise your hand if you think it's more easier. And this is the final X-ray after a union. So my surgical approach and my implant of choice, I use the Vola locking plate as the mainstream. And I use the Vola Henry approach. I incise the pronator chordatus in the midline and repair it as much as possible. And I usually do this case as the ambulatory surgery. So the patients go home after the surgery. After they are at the recovering room for observe the vital sign about two hours, and they go back home. This is the quality of the PQ that I repair to cover all the plate and decrease the hematoma. So this is the case that I want to share. We started the EEC one. This is the Fernandez one with the radial translation of the distal fragment from the brachioradialis. There's a comminution in the dorsal cortex. This case is extra-articular, so it's intact, the keystone, and the quality of the bone is good because the cortex is still thick. I usually do these techniques to reductions. I usually place the KY in the radial styloid and catch the metaphysis and manipulate the wrist position in the ulnar deviations to return the radial height, and see in the lateral side that can I restore the tilting into normal or a little bit volatile. And then I place the KY to temporarily fix. I place the screw at the metaphysis first, And then I positioning the wrist again and use the drill real time to see the good trajectory to catch the radial styloid and catch the lunate columns. And then I close it like this to decrease, let's say to decrease the flexor tendon tear and to cover the plate so that I can assure that the patient can go home. Another case is, this one is a little bit complex. This has radial column fractures and the lunate facet is fractured. And also there's a scaphoid facet also fracture, the keystone fragments. But this case doesn't have the radial translation and is a good quality of the bone. This case is a little bit long ago so that I didn't have the fluoroscope. So this is the initial reduction. Please look at the configuration. It's more easier, so you just place the plate. And this is the final X-ray. It's a little bit stepping at the articular surface, but it's healed quite good, and the patient has a full motion and full function and doesn't have any pain. Another case is, this case is one of my favorite cases. This one is dorsal shearing force. It's from Distal dorsal button. This one has a large radial styloid fragment. After the reduction, it doesn't help anything. And this case, please, I would like to walk a little bit. If you see this area, if you perform the volar approach, you see normal bone. You doesn't see anything because the fracture line is in the joint. But no worries. I put the bolster and the patient in the supine position. I flip in the lateral view and use the Carpentry technique at the dorsal cortex to flip it and fix from the volar side. This is the final X-ray of the patients. This case is sometimes when you encounter in the elderly patients, it's just only a simple extra-articular fracture with the radial translation of the distal. But this patient is osteoporosis. You see the cortex is very thin. The patient told me that he has the falling about 3 days. But after a reduction, the fractured fragment doesn't move at all. And so I asked the caregiver, the patient has a dementia, so the history is unreliable. When I operate this case, when I open it, I saw the callus. So that means this patient may be about 2 or 3 weeks. So after I clear the callus, there is a void, as you see, this one. So I do the same thing, use the KY manipulations, and I flip in the wrist in the ulnar deviations, and I use this KY to maintain that this fragment doesn't have any translation at all. I put the bone graft to fill the space. I drilled it and finish it like this. And this is my last case that I would like to share. This is my opinion, and this is my techniques that I do this thing when you encounter the distal bone fractures. Some of my colleagues, some of my mentors tell me that you just fix the radius alone is okay, or you fix the radius first and then you see the stability of the ulnar. But as you see that my reduction techniques is reduce the radius to the ulnar. So my strategy is fix the ulnar first as the pillar. This place is the radial column specific of the distal radius, but the contour is perfectly fine with the ulnar side. You see that when you fix the ulnar, the height and the articular surface return nearly normal. And after that, I do the same. Use the KY at the radial styloid and ulnar deviate to my firm pillars and fix the bone and complete it. This case has the large metaphysis, so I have to flip the fragments to make it more maintain the reductions and use a longer plate. And this is my final X-ray. So my take-home message is I emphasize you to do the initial reduction in every cases to ease the operations. And reduction the keystone, because this one is the essential. And you can do the adequate reduction by only use the KY for manipulation, the fragments at the radial styloid and positioning the wrist. And please beware about the bone voids in the osteoporotic patients, and screw positioning under the fluoroscope is easier to get the adequate and precise trajectory. And volar plating is appropriate in most of the cases. As I show you, the dorsal button even can manage through this approach. Thank you.